Very good evening, everyone. We are now in the third webinar of the series of webinars organized by the Explorers Society of the Faculty of Healthcare Sciences. The topic for today is something that many of you have encountered with, and most of you have heard about, and all of you must know about, and that is none other than dengue and living with dengue. And to talk about that, today our resource person is Dr. P. Mayurathan, who is a senior lecturer of medicine at the Faculty of Healthcare Sciences of the Eastern University. So as we are already behind the clock, without any further delay, let me hand the meeting over to Dr. Mayurathan. Sir, it's over to you to conduct the webinar, and we all hope that today will be a great day for us to learn something new.
Good evening, everyone. Yeah. Okay, I think all of you can see. Can you?
Yes.
Okay, so good evening, everyone. Thank you very much, Lalisha and the Explorers Society for inviting me today. The topic is challenges of living with dengue. So since most of the participants are medical students, I thought of preparing this mainly for the medical students. Today I'm going to discuss about the history of dengue fever and a little bit about epidemiology and something about dengue virus and the mosquito, and very little about dengue fever. We are not going to discuss about the management and what we can do to prevent getting dengue fever. So that is my outline. So if we see the history of dengue fever, it has been documented very long ago. First, it was documented in Chinese Encyclopedia of Symptoms during the Qin dynasty, and also they just called it initially the water poison, and associated with flying insects near the water. So that's how it was started many years ago. Then the first suspected outbreak of dengue-like disease were reported in 1635 in West Indies. After that, in 1779 to 1780, the first case was confirmed and reported the outbreak of dengue fever. It is not only in one country, but also in Asia, North America, and Africa. One of the American physician, Benjamin Rush, you can see his picture, he just described the fever as break-bone fever because of the very intense symptoms of this dengue fever. So now if we look at the Sri Lanka, the first recorded dengue fever reported in 1960s, and the first dengue outbreak confirmed in 1962. In between 1965 to 1968, there were about 51 cases and 15 deaths reported. From then onwards, we are having many cases, and the Sri Lanka became endemic of dengue fever. From 1996 onwards, dengue became a noticeable disease in Sri Lanka. So according to the WHO, dengue is found in, we all know, the tropical and subtropical countries worldwide, and they describe about half of the world population is now at risk of developing the dengue fever. It's estimated about 100 to 400 million infections every year, and very significant amount of death as well. So I didn't go in detail about many years, so I just took last 2 years, 2020 and 2021. If we see 2020 in all Sri Lanka, about 31,139 cases were reported. But 2021 up to yesterday, just completed only 2 months, we have about 3,523 cases. I just want to highlight why we are discussing about dengue today. If you see in 2020, the particular RDHS area was the second place out after the Colombo, because there were about 3,717 dengue cases were reported from particular RDHS area. That is, if you can see the whole island, it is second place. We were at the second place. Interestingly, up to 5th of March, just completed only 2 months, as I said before. We are leading in Sri Lanka. So the particular RDHS area has reported 2,120 dengue cases. And according to the regional epidemiologists, this year we are dealing with very, very bad outbreak of dengue fever in particular. So it is separately mentioned. So Kalmuna RDHS area only 77 cases, Ampara only 6, Trincomalee 36. But we have more than 2,000 just within about 65 days from this year. So if you see the particular RDHS area, this total cases in this year is 2,120. We have up to now 2 deaths. But in 2020, I'm not sure these figures are correct. I heard this is only 4 deaths in particular RDHS area. If you see the whole island, it is again, these figures I'm not sure. In 2017, about 205 deaths. 2018, 74 deaths. 2019, 58. But last year, the whole island wide, 23 deaths, but it's only 4 from our area. So dengue fever is a viral infection. I think you all know that. It is transmitted by mosquitoes. So definitely we need a vector for this infection. So dengue virus is an RNA virus. It's a Flaviviridae family. There are 4 different serotypes are there. We call dengue 1, 2, 3, 4. And some people say there is another serotype. There may be 5 serotypes, but it is not very much reported. Each serotype is known to have several different genotypes. This because of these viral genotypes and serotypes, the sequence of infection with different serotypes appear to be affecting differently, and the disease pattern and the severity also different depending on the serotype. So if you see the mosquitoes, so mainly the Aedes mosquitoes are spreading the infection, Aedes aegypti and Aedes albopictus. You can see we should be able to identify this mosquito because it's very closely living with humans. So it is a black color mosquito with white color dots. So that is the characteristic appearance of this Aedes mosquito. So I just want to concentrate on this life cycle of the mosquito. Then only we can understand how can we prevent this mosquito breeding. Okay, so it takes about 7 days to become an adult mosquito from the eggs. It has 4 parts: eggs, larva, pupa, and the adult. So this mosquito is mainly breeding in the stagnant water. Okay, so it's 80% clean water, but mainly the stagnant water. So if you see the eggs, it is black in color. And specifically, the eggs can withstand in very dry conditions for many, many months. Okay, so these eggs can survive for many months. That is one reason we couldn't control this mosquito. And also, there is a trans-ovarian transmission of this virus. That means if the virus is there within this egg, when this egg become an adult mosquito, that mosquito itself can spread the virus no need to bite an infected person. So it is another risk factor, or the important factor we should consider. That is another reason we could not able to control these mosquitoes, because when this infected egg become an adult, that can infect people with no need to bite another dengue patient. These larvae, they need water for their development, and so typically they will hang upside down in the water surface, and this will become pupae and subsequently can change into adult. So within 2 days of adult life, they can mate and they can have a blood meal. So it's very specific. So within a week, we may not aware that it is living near us, and it can become adult mosquito and it can bite and causes infection. So it's mainly feeding during the daytime. So peak activity may be dawn and the dusk. And very specifically, they are very aggressively feeding female mosquitoes. They like to bite and feed more than one human, okay, more than one person. It can able to bite. And it is mainly indoor as well as the outdoors. And another point about this mosquito is it can lay about 100 to 300 eggs within their lifespan. So one adult mosquito can produce about 300 another adult mosquitoes. And the mosquito can fly only up to 400 meters. So it can't go more than many distances to spread the disease. So it is very close. Okay, within 400 meters only, the mosquito can fly and can bite and cause us problem. So when humans are infective during the first 3 days of the illness, so for example, if I develop a fever due to dengue infection, within first 3 days, so we will become infective in 3 days time. And when a mosquito bite that person, in about 8 days to 2 weeks time, the mosquito become infective. Okay, so after that, until that mosquito dies, it can spread the fever in dengue infection. So up to the whole life, it's about some books say it's about 1 month, some books say it's about 100 days the mosquito can live. Roughly about 4 to 6 weeks, the mosquito can spread the. So this point we should remember, because when a patient comes to the hospital fever, so they are already infective, that bitten mosquito will be there at their house, and that mosquito will spread the disease until that mosquito dies. Okay, so they have to be very vigilant. Okay, so this is again when the mosquito bite infected person. Then within about 8 days, in about 8 days time, that mosquito is infective. So it will bite other people and causes the infection. So common symptoms or clinical features of dengue fevers are, with fever, they can have headache. We say retroorbital pain is very characteristic. Sometimes they can develop skin rashes, muscle and joint pain, and sometimes very tired. These are the very common symptoms of dengue fever. So it is every day, most of the time, many people complain about these symptoms. So it is not very specific for dengue fever. Okay? Sometimes we say retroorbital pain, but everybody might say that I have aches and pain. Okay? So with this, patients can present. The incubation period is about 5 to 6 days. So if you take the dengue fever pattern, so majority are asymptomatic, or they may be having very mild symptoms. If they become symptomatic, we can divide the pattern of dengue fever into 4 undifferentiated fever or dengue fever, dengue hemorrhagic fever. The last one is expanded dengue syndrome. So undifferentiated fever is, you may not be able to differentiate from even a common cold-like symptoms. Okay, so the dengue fever and dengue hemorrhagic fever can cause bleeding, but dengue hemorrhagic fever causes shock, then that causes death. So undifferentiated fever, it may be just a simple fever, okay, very difficult to differentiate from other viral infections. Generally, we just manage symptomatically with the people might need admission. So these people definitely have headache, myalgia, arthralgia, and rashes. Investigations, you can see low WBC and low platelets. Sometimes they can present with bleeding. It could be epistaxis or menorrhagia or some very rarely GI bleeding. So symptomatically, we manage these dengue fever patients with fluids, rest, and if necessary, paracetamol. So dengue hemorrhagic fever is the dangerous one. So it typically, initially, people were describing about 3 classical stages like febrile phase, critical phase, and the convalescent phase. But nowadays, we see sometimes it is very difficult to differentiate these 3 phases. Some patients might start critical phase within the febrile phase, and sometimes the febrile phase is very long and it might continue even after completing the critical phase. So there are different patterns we could be able to observe recently, and that is another challenge for the healthcare professionals to identify, sometimes causing problem in managing this dengue fever. It can kill, so this is very dangerous. So unfortunately, we don't have any specific markers on admission to predict who are the patients will go into just a dengue fever, who will develop dengue hemorrhagic fever. There is no any specific blood test or anything to predict their clinical progression. So almost all the patients, when they come to the hospital, we assume anybody can develop dengue hemorrhagic fever. So all of them needs very close monitoring. So how can we confirm dengue fever? So we can confirm, it's very easy test, okay? So we can do a blood test called NS1 dengue, NS1 antigen. But you may have to remember, this test is very sensitive within the first 5 days of fever. Sometimes it may be negative on day 5. So if you do on day 1, it's 100% sensitive, then the sensitivity goes down. When on day 5, it could be negative even. But after day 5, we may have to do Dengue Igm antibodies. So it's again on day 5, it also could be negative. So after 6-7 days, we can detect Dengue Igm antibodies. These are the 2 tests generally we do. If the patient comes within the 5 days of fever, then we always go for NS1 antigen. If it is after 5 days, we do IgM antibodies. We can detect the serology by doing a PCR, but it is available in Sri Lanka, but not very widely available. Better to do this dengue serotyping to identify the pattern or something like that, but it is not necessary to manage the patient. Okay, we don't need to know what is the serotype of dengue fever because it won't alter the management. If anybody is having the dengue fever, we ask them to rest and also take adequate fluid, so without overloading, without underloading. So any fluid like oral rehydration fluid or king coconut water or any other fluid juices they can take. We generally ask them to avoid any black or brown or red color fluids because sometimes if they start bleeding, we may not be able to differentiate whether it is due to the drink or actual bleeding. That is the only reason, otherwise they can drink. Specifically, we ask to avoid non-steroidal anti-inflammatory drugs like diclofenac sodium or any steroids. And also, if somebody is on antiplatelet like aspirin or clopidogrel, we withhold these drugs when a patient develops dengue fever and the platelet goes down. Okay, so these decisions we take when they come to the hospital. So roughly you may have to remember that antiplatelets and drugs like non-steroidal anti-inflammatory drugs should be withheld or stopped whoever is developing fever. So we don't know who is going to have the dengue fever. So now this is the very important part, because this is the challenge for us in the preventive side. So how can we prevent? So it's definitely a teamwork, and everybody in this world, including Sri Lankan, should be involved. Okay? Without people's support, we can't prevent the dengue fever. Basically, we can divide into three parts. First one is to prevent the breeding places and prevent mosquito bites. The third one is giving some vaccine to prevent the disease. Okay, so we can basically say under three headings. So what are the breeding places? We should know the breeding places, then only we can take the steps to stop these breeding places. So you all know the tires with water, very common breeding places. So I'm going to move these slides very fast, I think, because there are lots of slides. So I'm going to move, you can see. Again, tires, water storage barrel, you can see, because 1 week is enough for this mosquito to breed and become adult. So see this, it's anything maybe they are near to us. So water storage buckets and the cement tank, you can see, block gutters, well, without any fish or cover, there are mosquito breeding, we can see. Refrigerator tray, it's okay, it's another common place within the house. And concrete slab, so if it is kept unclean for 1 week, then there will be mosquito. Flower pots and unfiltered water, and flow with water if it is not cleaned. Pipe outlets, discarded items, you can see many discarded items. There are water collection and the mosquito breeding places. Unused tube well, okay, water filter, even the soda case, again lot of discarded items. See that anything may be near us. Overhead cement tank, pots, polythene covers, there may be water collection. Unused squatting pan, closed or abandoned toilets and commodes, cistern without a lid, another common place. Again, overhead plastic tank without a lid, gully trap, you can see that. Sink, leaking sink, there may be containers with water. And ornament, this is we use for the decoration. It is kept unclean. And pond, trolleys, fish tanks without fish, and any shell, would be the egg shell or coconut shell or anything with the water. a lot of other household items. Leaf axils, you can see there may be a water collection and mosquito breeding. Tree hole, specifically bamboo stumps and banana cuttings can be the breeding place. Abandoned boats, shopping bags, sometimes poultry containers, some water drain areas, ACs, flag holder. So there are a lot of places you can see. All these places are potentially mosquito breeding places. So we have to be very vigilant, and there should be a very close monitoring repeatedly, maybe at least twice a week. Then only we can identify these breeding places. Otherwise, we might miss. So the question, how can we modify these places? Okay, so overhead tank with the lid, we can modify that. Nowadays, you can see that the overhead water tanks are coming like this with a very good lid setup. And regular monitoring and dengue control activities, and you can see that they go home by home and doing all the necessary things, including covering these wells and putting mosquito-proof nets, covering the unnecessary unused places, and specifically looking for any water collection, and this PHI and other staff looking for any mosquitoes or with their specific features, looking for any Aedes mosquito. And another thing is fish. Larvivorous fish species are very specific, and this is the fish, and this can eat this larva, and it can control the spread of the mosquito very effectively. So that is why nowadays the PHI and all specifically coming and checking for whether we have fishes in our well. And fogging for mosquitoes is another way of prevention. And how we can prevent mosquito bites. Okay, so wearing a very long clothes or putting a mosquito nets, and using specifically some mosquito repellents, and sometimes you can apply some mosquito repellents. There are various products available in the market. So finally, dengue vaccine. So there is a vaccine, effective vaccine, that has been registered in December 2015. We should take 3 doses, but unfortunately it is not registered in Sri Lanka and we don't have. So it is approved for the 9 to 45 years of age, because people think that younger people are the common people to get dengue infection, but it is not always correct. Nowadays we see very elderly people, 75, 80-year-old people also coming with dengue fever. So if you see that why we could not able to control the dengue fever, what is the challenge we face, is mainly due to the mosquito breeding places. We may not be able to identify, or we just ignore it. That is main reason. And we are not doing repeatedly. Sometimes people, 1 or twice, they will check the places around us, and after that they stop doing that. And very specific features of this dengue mosquito, especially the egg, and also the characteristic features of the adult mosquito, including the larva and pupae. They can survive very easily for many months. And also the dengue virus, even though we say 4 serotypes, and the mutation in these viruses may cause different clinical patterns. and different clinical presentation, we may not sometimes fail to identify. So this is, I'm just talking about the preventive part. And if you come to the curative sector in the hospitals, also might have some problems. So nowadays, the main problem in Vaticlo we face is massive number of patients are coming to the hospital, and every day more than half of the ward is filled with the dengue patients. And few years ago, we don't see many dengue patients going into the dengue hemorrhagic fever. Nowadays, almost everybody, or more than 75–80% of the dengue fever patients are going to dengue hemorrhagic fever. They develop dengue hemorrhagic fever. So monitoring those patients may not happen sometimes because of the lack of staff in the hospital. You know that everywhere in Sri Lanka there is a shortage of health staff, especially the nurses, sometimes the doctors. Because in dengue hemorrhagic fever, we have to monitor them every hourly, and even if you miss 1 hour, and we may not be able to get it back. So patient, you may not survive, help them, so they might die, even if you miss 1 hour monitoring. So because of these many reasons, we have difficulties in controlling the dengue. I would like to thank Dr. Darshini Murugapalli. She is the one gave me a lot of these beautiful images of breeding places. These all collected in Vaticlo. These all the images when she was a regional epidemiologist. Thank you very much. I think now you can ask questions.
Yes, sir. We have a question from Joshua.
Yes.
Can dengue spread by breast milk and needle prick injury? Breast milk and needle prick injury.
I don't know. I would say no. Okay, generally, when a dengue pregnant mother become pregnant, or if she deliver the baby, when they ask about the breastfeeding, we say yes, you can. Okay, so I don't think dengue can spread by the breastfeeding. What is the next? Needle stick injuries. Huh?
Yes, sir. Yes.
I'm not aware of that. I don't know. So maybe Dr. Ramesh might answer. If somebody asks, I would say no, because needle stick injury, I don't know. My answer is no, but let me ask from other experts and tell. Okay, I will inform Joshua about it. Okay, breast milk, no, I think, because even myself have asked many pregnant mothers DHF or dengue fever when they deliver the baby. Immediately we ask them to start breastfeeding.
Yes, these are the good questions. Hello?
Yes, please.
Yes, I think theoretically with the needle prick injury, if the needle prick injury from the infected person within 3 or 4 days, theoretically he can get the infection from the person. So I don't aware of this any case reports similar. This needle prick injury can cause dengue viral infection. But this breastfeeding also, I don't think it can be spread through the breastfeeding. So that also we have to search for any case reports or anything in the literature.
Recently, I had a patient, dengue hemorrhagic fever, and she delivered the baby during the critical phase. But we asked the mother to feed immediately. Okay, the baby was all right.
Thank you, Mayuradhan, for the excellent presentation.
Yeah, it's Friday.
Yeah, so I totally agree with Dr. Ramesh. Yes, theoretically, yes, with the needle prick injury, and okay, you can get it, but there's no known reported cases like that. And the breast milk, yes, again, it's a query, but intrauterine transmission is possible, but through the breast milk is again a query.
I think there is no any other questions, isn't it?
Thank you, Dr.
And I would like to ask from Dr. Vaidehi, why this vaccine was not registered in Sri Lanka? What happened to that? Because initially the phase 3 trial, Sri Lanka, 10 countries, Sri Lanka also included into this trial. Then what happened? Do you know anything?
Yeah, actually what happened was dengue, that vaccine was initially introduced in Philippines and some other South American countries. So
Yes.
Philippines has got a very, very, very bad outbreak of dengue following the vaccine. So then the vaccine, Sinopharma, so then they declared if the vaccine was given on a naive person, that means that not infected previously, and when that vaccinated person gets the infection as a primary, he will react as a secondary infection, severe outbreak and severe disease. So that's the very reason epidemiology unit and the National Advisory Committee didn't recommend dengue vaccine for Sri Lanka. So still it's in the discussion, because if we are able to, then there was a zero prevalence study also. Part of the surveillance, that whether we all have, how many % of population have the dengue antibodies in their body. So in that case, then we can have an idea how many % we are exposed. So then we can go for the vaccine. But still, the dengue pathophysiology is very complex, and it's the antibody-induced pathophysiology. So it's very, very tricky, the virus, the vaccine to prevent such an illness. So again, as you pointed out, Mayuradhan, this is the prevention, and to look out for breeding sites regularly. That is the way forward, and that is the promising one than the any vaccines up to now.
So my recommendation is every day we have to open our eyes and specifically look for dengue breeding places, and regularly at least twice a week around us, especially inside and outside our houses, because the mosquito can't fly more than 400 meters. So it is living with us. So if one person next door is infected, means either mosquito might be there within our house. So we have to be very vigilant, and specifically we have to search for dengue mosquito breeding places.
Thank you very much, sir, for that answer. And,
I would like to point out a small one.
Yes.
That our own experience, that we found dengue mosquitoes in the department. Then every day, that was a big problem. We found that. So then what happened? We just walked around, and we found near the toilet pits, that construction site, and not in the toilet pits, near that there was an old, just a removed gutter, and no water in it, but just a wet sand was there. And we were able to see some Bernie-like thing moving, and then we took the sample and saw under the microscope Aedes larvae. So this is like very, very tricky. So then the cleaning service people told, தண்ணி இல்லாதால நாங்க அதை பார்க்கல. So they just thought no water, no water accumulation, but it's again a wetty, sandy, wetness is enough for this Aedes to breed. So remember that.
People, the experts say that even a little bit of water collection within this cap of this soda bottle is enough. A small water collection is enough for this eggs. Okay, the eggs may be there for many months in the dried condition, but when the egg see the water, exposed to the water, immediately it can catch and it can continue their lifespan and become the adult mosquito within days. So that is the problem.
I want to ask a question to Dr. Mayuradhan.
Yes.
How much this fogging is effective against this dengue mosquitoes?
Yeah, I don't have any figures to tell, but it is not very effective. It is not very effective. So compared to this destroying these breeding places and putting some physical barriers like mosquito net, compared to these, this fogging is not very effective.
Okay.
I don't know the exact percentage of the effectiveness, but it is not very effective way of killing the mosquito. Why they anything, any idea?
Yeah, yes, fogging actually targeting the adult mosquitoes.
As adult mosquitoes,
Yeah,
yes.
if we have a patient and if you when you are notifying, so then what the PHIs do, so they immediately go there and do fogging. So that is one of the way of controlling, because that time the active source is there, and if we need to target the adult mosquitoes then and there that time. But for the long term, then again breeding places. But fogging, that it should combine very nicely. Otherwise, it's and then that's now evidence. Now I don't know why Baticlo has such a hit of dengue, but one of the thing, our PHI team is now very busy with the COVID, and the dengue activity is coming second, third, fourth line measures. So then now fogging is almost comes to near zero because they don't have time. And especially I should thank Darshini because she's doing a lot for the dengue control in the region. So then that's she also talked to me. Then she also doesn't believe much in the fogging, but still now we are seeing how we don't have fogging, we have more dengue. So I don't know correlating together, but it also points out the breeding site elimination plus adult control should run parallel. So then it's effective.
So there's another question from Sufat. Is it possible to have 2 strains of dengue virus infection at a time? It is possible, theoretically, it is possible. So if there is 2 serotype infection can occur at the same time if we get 2 different bites.
Exactly. It can happen. Yeah.
I don't know what is that. Whether that is the actual question he wanted. Sufat, are you there? What is the question?
Yes, sir. Maybe due to the 2 bite at a time, whether it will worsen the clinical consequences.
Yeah, I was thinking that maybe your question. So because there are 4 serotypes, when we get 1 serotype, say for example, dengue serotype 1, after infection, we might develop immunity for that particular virus. So dengue virus. But when we get the second virus, so after that maybe 2, 3 or 4 bite us, when we may not have immunity to that serotype, but they say because of this other virus immunity, because these all are immune mediated, and also the pathophysiology I didn't touch here. So exact pathophysiology we don't know. So as you all know, we are learning every day. So every dengue patient teaches something to us, something. So see that I'm doing like this, something. So they say because of the previous infection, when the next serotype infection can cause very severe form of disease. That only we can say. That may be the reason for this vaccine also. So I don't know how many of you understand Dr. Vaide's comment. That may be the reason people had a severe infection after the vaccination.
Two serotype at a time is evidence with our serotyping study as well, because the regular surveillance going on last year, and we had cases with dengue 1 and 2 together, dengue 2 and 3 together in one sample. So that means the 2 serotypes can infect at a time on a patient. That can happen.
there is one more message. Okay, thank you very much.
Sir, if you have time,
yes, please.
There's another question sent by a student. Why dengue patients develop retroorbital pain, and how is it developing? Is it only special to dengue?
It's a difficult question. We don't know what is the exact reason for the retroorbital pain, but it is not only to the dengue fever, but it is characteristic for the dengue fever. Characteristic means when you read something is characteristic, that might be there for many diseases. But dengue also, we specifically ask about this retroorbital pain. So it's all very long. Few years ago, we asked that because we don't know whether it is dengue fever. Nowadays, it's very easy to diagnose. No, within when they come within hours, we get the reports and we diagnose dengue fever. Maybe within 1 or 2 hours immediately after the admission. We specifically sometimes don't ask about the retroorbital pain nowadays because we diagnose straightforward diagnosis. But I don't know the pathophysiology for that. I don't know anybody as a participant knows why what is the pathophysiological reason for the retroorbital pain.
Difficult, Myrodhan, to define how it has but anyway, acute inflammatory process can cause aches and body because the cytokines. But why the cytokines specifically act on retroorbital parts, I'm not sure. I don't know. I'm sorry.
Maybe we will try to find out that. And there is another question. Can we develop immunity after infection? Yeah, I think I have answered to that question. Yeah, one serotype, we develop immunity. So because there are 4 serotypes, still another serotype can cause severe disease. So we generally call partial immunity. Okay, we don't say immunity.
Students might recall your immunology, that opsonization process. So if there's antibody there and the virus is come, the virus and antibody binds together, and our macrophages and our phagocytic cells will get activated by that. So it's well and good if it is activated in a proper way, it will be killed. But in dengue, it's activated in an opposite way. So it's antibody-induced pathophysiology. So that's what it happens. So then, but for that particular serotype, it's good. But for the next serotype, it induces the disease process. So, but it's quite interesting. And there's a very good study by Professor Neelika Malavige Japura. And if students are interested, you can go through. I'll share the link at your club WhatsApp group.
So there is another question. Some people say papaya leaf juice is effective to increase the platelet. Is it proven in any studies? So I think Simanjali. So not only papaya leaf juice. Some people just eat raw papaya or papaya juice, the fruit juice. Also people drink. I have seen many people. So the reason behind it, the papaya has some steroid. So people say that when they take the steroid, the platelet count will increase. But I don't think there is any scientifically proven study for this papaya use. But the main reason is it has some steroids.
Okay, thank you, Dr.
There is another question. The critical phase from which hour we start fluid management and how? Okay, so Lalisha want to know. So Lalisha.
Yes, the question was from Tavisha. I had mistakenly replaced it. I had mistakenly, yes.
Okay. So critical phase is, I thought not to talk about the management. because you all will study about it, and you will study in detail when you study the microbiology and medicine. This presentation I wanted to tell mainly about prevention part. So Dr. Darshini, specifically when I asked her opinion about what to present today, the audience is the majority are the students. So she mainly want to highlight about these breeding places and the prevention, because that is cost effective. Definitely cost effective when compared to one patient coming with the critical dengue hemorrhagic fever, and we are struggling to manage. So when critical phase is generally 48 hours, but sometimes it may be shorter, sometimes may be longer. So when someone come to the hospital before the critical phase, so we do a lot of examination and investigation, including bedside scan. There is no leakage. Then we manage them as a dengue fever, and time to time we do the scans and examining the patient and doing the blood test, looking for platelets, PCV, various investigations and the examination features to identify the critical period. So when somebody is in the ward, we don't have much problem to diagnose what is the critical period, the timing, the onset of the critical period. But some patients coming with the fever and not an admission, there is a leakage, then we don't know when was that critical period started. It is very tricky. Sometimes it may be just a few hours before, they may be maybe more than 12 hours or 24 hours, maybe close to the end of the critical period. We don't know. So again, we go by the history about how many days of fever and each and every features of suspecting that abdominal pain, so many features. Roughly we take 6 to 12 hours before the admission, the critical period has started. Okay, so 6 to 12 hours we take. So I always take 6 hours, I don't take 12 hours before the admission, because if you take 6 hours, then your monitoring time will be more after the admission. So if you take 12 hours, then you are going to monitor only 36 hours after. If you take 6 hours, then you will monitor them another 42 hours. So I take only just 6 hours before the admission, then we monitor them for another 42 hours. So the monitoring time will be long, so you will not miss anything. We don't know. I don't think any examination feature or anything will tell you the time or onset of the critical period. We don't have that information. It is very tricky.
Yes, only thing we can compare any previous hematocrit values, any outside or any previous before admission with our current hematocrit to just guess when it can occur. Yes, as you said, otherwise it is very, very difficult to determine this when the onset of the leaking, when patient comes late to hospital. So anyway, the duration of the fever is very, very important. As you said, 3 days. Up to 3 days, it's a very less chance of leaking. So 3 to 6 days, usually they leak. So duration is fever is dengue fever, very, very important. The history, very, very important than other viral fever or other bacterial fever. So that we have to concentrate on that part. Then examination doesn't tell the onset of these things. Other thing, we have to go by the hematocrit history and yes.
If they have a blood count before admission, it might guide, but sometimes patients might come. So another, because of this question, I would like to highlight. Earlier, we just tell the people or public, because it is also viral fever, we generally advise them to go to the hospital and check your blood 3rd day of fever. Okay, that is how we advised earlier. But nowadays, because we have seen early onset of leakage, we advise 2nd day onwards, people should seek the medical attention. They have to go to the hospital or they have to check their blood count. 2nd day onwards, don't wait for 3rd day. Okay, because we have seen people are coming on third day with the leakage. Another question.
Hello, sir. Yes, that was my question, and I would like to ask that is the critical phase depends on the serotype of the dengue?
I don't know this serotype causes this much hours of critical phase. We don't divide like that. Okay, all the viruses we say critical phase is 48 hours. Okay, but I don't know any serotype is specifically shorter or longer. Generally, it is 48 hours, but practically we have seen maybe the critical period little longer than 48 hours. Sometimes it is very little shorter than the critical period, but you don't need to worry or you don't need to study anything according to the serotyping. Okay, another question, sir. Why right side pleural effusion is commoner than left side in dengue fever? So that is from Lamuel. So we ask this question, Lamuel, when you come to the final year. So the reason is right side of the lung has 3 lobes and the surface area is more than the left side of the lung. Okay, when the surface area is more, leaking is more on the right side. So first they develop on the right side, but later on they will develop on left as well, okay, because of the more surface area on the right side.
Yes, since we have gone past the time limit as well, I think yes, I think we can end the Q&A session now. So Dr. Mayuruthan, thank you very much for today's session, and especially for taking time and effort to make an interesting presentation, and also everyone who involved in the conversation, especially Dr. Vaidehi and Dr. Ramesh, Dr. Sivanjali, and everyone else, all the students. So I guess we are at the end of the session today. Hopefully, I think we all got to know a lot of things today, and the credit goes to Dr. Mayuruthan for his efforts in this regard. Therefore, I think now it's time for us to conclude today's session, and thank you, every one of you, for joining, for staying with us, and for adding some interesting questions to the meeting. And do join with us in the next time with the next webinar. Thank you, everyone.
Okay, thank you, Lalisha. Thank you, everyone. It was interesting discussion. Good night.
Good night.